Welcome to the deep dive. Today, we're digging into monoplace hyperbaric chambers, those single-person pressure units.
Right, and specifically how they're used for treating decompression illness, DCI, in divers.
Exactly. We're going to look at the history, what they can actually do, and some of the ongoing discussions, maybe even debates
Yeah.
around them.
Yeah, it's a fascinating topic. We'll be drawing on our sources to really unpack their role, both in diving safety and medical treatment.
Okay, let's jump in. The whole idea of hyperbaric treatment, it actually goes way back, doesn't it? Like 19th century.
It does. Think compressed air workers, people building tunnels under rivers, like the Hudson River Tunnel Project. They had these huge multi-person steel chambers.
Right on site.
Absolutely. Considered essential back then. They needed to treat what they called caisson disease, what we now know as DCS, decompression sickness.
Get those workers back under pressure fast.
That was the idea. Recompress them immediately. And the science behind it, Boyle's law, hasn't changed.
Pressure goes up, volume goes down.
Precisely. So for a diver with the DCI, you've got nitrogen bubbles causing problems. Increase the ambient pressure in the chamber, and those bubbles shrink. It's a fundamental physics.
But those early chambers were massive, not exactly portable for, say, a dive boat.
Not at all. They were built for large groups. But as recreational and technical diving took off, often in remote locations, well, the need for smaller, more transportable options became obvious.
And that's where the monoplace, the single-person chamber, comes into the picture.
Exactly. Designs that could, potentially at least, be brought closer to where the diving incident happened.
But how are they typically used in that diving support role? Seems like there are two main approaches.
Yeah, basically two strategies. One is immediate, definitive treatment right there on site, if the chamber and the situation allow.
Okay.
The other is stabilization. You put the diver under pressure in the monoplace, basically holding them stable, for transport to a bigger, probably hospital-based multi-place facility.
And you can actually transfer them under pressure? How does that work?
It's pretty clever. Sometimes the monoplace has a flange, a special connector, that can seal directly onto the multi-place chamber's entry lock.
Ah, so no pressure change for the diver.
Correct. Or, if the monoplace is small enough, you can physically place the entire unit inside the multi-place chamber.
Wow.
Then you pressurize the multiplace, open the monoplace, and move the patient across. All done under pressure.
That's smart. And you mentioned portability. There was a big leap forward there too, right? With different materials.
Oh, definitely. The development of fabric-hulled, lightweight monoplace chambers, maybe around the 1980s, was a real game changer.
Fabric, like not metal.
Yes, strong, flexible materials. Some of these are incredibly portable. You hear stories of them fitting into large suitcases.
That's amazing. And they can still deliver proper treatment.
Critically, yes. Many are capable of delivering, for example, the U.S. Navy Treatment Table 6, USN TT6.
Which is a standard effective DCI treatment protocol.
Exactly. So you get portability and effective treatment capability. It really opened up options for remote diving operations.
You can really see the value in places far from medical centers, like Cocos Island was mentioned.
Oh yeah, Cocos is a classic example. Way off the coast of Costa Rica, fantastic diving, but if someone gets bent,
You're stuck?
pretty much. It's like a 30-hour boat trip back, no airstrip, helicopters can't reach. Having a monoplace chamber right there on the live aboard or the island itself, that can be the difference between life and death or permanent injury.
Yeah, there was another example mentioned too, San Benitos Island, off Baja, California. Sounded like a really tough retrieval.
It just highlights the challenges. These chambers, used in support of diving, are widely accepted. They save lives, they can reduce the severity of neurological injuries, potentially prevent someone from being medically disqualified from diving again.
So for on-site support, remote operations, monoplace chambers are pretty much accepted, even celebrated.
Absolutely. Their value there is pretty clear.
But, and here's the twist, it seems. When you talk about using these same chambers
Yeah.
in a hospital setting for DCI, suddenly there's controversy.
Yes. Which is, on the surface, a little surprising, isn't it?
It seems so. Why the debate when they're in a hospital? Let's trace that back. How did they even end up in hospitals?
Well, multi-place chambers started appearing in hospitals back in the 1960s, not primarily for diving at first, but for other conditions.
Okay.
And around the same time, there was a lot of interest in using hyperbaric oxygen, breathing pure oxygen under pressure to make radiation therapy more effective against cancer.
Ah, the radiotherapy connection.
Exactly. And that led directly to the development of the acrylic-hulled monoplace chamber. The clear acrylic meant you could deliver radiation through the chamber wall while the patient was inside, pressurized, breathing oxygen.
Clever. And probably cheaper than a big well place.
Much more cost-effective for hospitals wanting to offer hyperbaric oxygen therapy, HBOT, for various approved conditions, not just radiation sensitization. So they became quite popular for general HBOT use.
And over the years, technology improved. They could handle sicker patients.
Definitely. Biomedical engineering advanced. Now you can run IV fluids and medications through special ports, monitor ECG, even provide mechanical ventilation in many monoplace chambers. They've become quite sophisticated.
Which makes the pushback against using them for DCI even more puzzling. You've got a controlled hospital setting, chambers that meet minimum U.S. Navy specs, decades of use, positive reviews. So what are the criticisms?
It is puzzling on the face of it. Let's break down the main points that are often raised. One big one is patient isolation.
Meaning no attendant inside with the diver, unlike a multiplace.
Correct. In a multiplace, you can have a nurse or a medic inside, constantly assessing the patient, noticing subtle changes, making decisions on the fly, like extending the treatment table if needed.
Right. So how do you manage that in a monoplace? Can you really monitor effectively from the outside? What if you need to extend the treatment?
Well, experienced monoplace programs have protocols. For instance, the source mentions a practice where they formally assess the diver at a specific point, the start of the third oxygen cycle, at 2.8 atmospheres absolute, or ATA. That's about 92 feet deep equivalent.
Okay.
If the diver's symptoms are gone by then, they stick to the standard table 6. If not, they can initiate extensions right there. They reassess again later at 1.9 ATA, around 30 feet, to see if more extensions are needed.
So structured decision points replace constant observation.
Essentially, yes. They've apparently managed treatments up to 8 hours long this way, using all 4 possible extensions. It requires good communication and a clear plan, but it's doable.
What about just general monitoring, oxygen delivery? Potential problems like oxygen toxicity.
In a multiplace, the inside tender watches the mask or hood system delivering oxygen. In a monoplace, the patient is breathing the chamber atmosphere, which is 100% oxygen. So you don't have the potential mask fit issues or oxygen percentage variations you might get in a multiplace.
And you can see the patient clearly.
Yes, through the acrylic hull, the operator watches closely. If they see signs of CNS oxygen toxicity, twitching, confusion, they can instruct the patient, if able, to take air breaks using a mask.
Okay, but what if the patient has a full seizure? That sounds terrifying in a small, locked chamber.
It does. But interestingly, the experience suggests you don't necessarily need to immediately stop the oxygen if a seizure occurs in a monoplace.
Really? Why not?
Observations show the seizure often stops on its own relatively quickly as the body metabolizes the excess oxygen, similar to if they were switched to air in a multiplace. But to prevent a second seizure, once the first one stops and they're breathing okay, you do decompress the chamber.
How fast can you decompress a monoplace in an emergency?
That's actually a key point. It's fast. Around 2 minutes from maximum pressure back to surface pressure.
Much faster than a multiplace emergency decompression.
Significantly faster. Rapid decompression in a multiplace is dangerous. For the inside attendants, puts them at high risk of DCI themselves. There's even a case mentioned where an attendant got seriously bent during an emergency abort for a patient issue.
Wow. Okay, that's a factor I hadn't considered. But you can't do CPR in a monoplace during decompression, right?
That's true. That is a limitation. CPR can be performed in a multiplace while decompressing.
Okay, another criticism was about air breaks. You mentioned the patient breathes 100% oxygen. Early monoplace chambers couldn't do air breaks.
Correct. The standard U.S. Navy tables, like TT5 and TT6, include periods where the diver breathes air to help prevent oxygen toxicity. Early monoplace designs couldn't easily switch the breathing gas.
So they needed different treatment tables.
Exactly. That led to the development of specific monoplace treatment tables that were shorter and didn't require air breaks. And surprisingly, these tables have generally proven quite effective over the years.
But modern monoplace chambers can do air breaks now.
Yes, most can. They adapted by introducing oronasal masks, similar to multi-place setups connected to an air source. The National Board of Diving and Hyperbaric Medical Technology actually recommends all chambers, mono or multi, should have air brake capability now.
So how do you give an air brake? Just hand them a mask. What if they're unconscious or ventilated?
Good questions. For an alert patient, yes, an oronasal mask works. If they're maybe agitated or restrained, a face tent can be used. For patients with a tracheostomy, there are track collars. And for ventilated patients, the ventilators can be adapted to deliver air cycles.
So there are ways, But you wouldn't just like flood the whole chamber with air for the break.
No, definitely not. That's considered ineffective and shouldn't be done. The patient needs to breathe concentrated air while the chamber remains pressurized with oxygen, usually.
Got it. Okay, what about the idea that monoplace chambers just can't handle seriously ill patients? Not enough medical support possible.
That's another area where things have really changed. Modern units have through-hole penetrators, special ports, for a 5E line, so you can give fluids and drugs, for electrical connections, so you can do ECG monitoring. It's even possible to monitor central arterial and venous pressures in some setups.
Okay. What about giving IV fluids under pressure?
They use manually operated pressure infusers, like a cuff you inflate around the IV bag, to overcome the chamber pressure. Works for things like heparinized solutions, too. There used to be a special non-invasive blood pressure monitor for Monoplace, but apparently it's not available anymore.
And things like chest tubes, ventilators.
Chest tubes can be managed using one-way Heimlich valves. Urinary catheters are routine. And yes, as we mentioned, there are specialized monoplace ventilators now, with advanced features like PEEP and CPAP adaptable for air brakes.
So quite a bit of critical care is possible. Any major limitations remaining?
The one mentioned in our source is in-chamber suctioning. That's generally not feasible currently. So patients needing suctioning would typically have it done thoroughly right before going into the chamber based on experience and assessment.
Okay, so capable of handling fairly complex patients with that one caveat. What about pressure? Was there a concern they couldn't go deep enough?
Yeah, that criticism stemmed from a time when treatments involving pressures higher than 2.8 ATA were more common.
And 2.8 ATA is the max for USN Table 6,
Right.
about 60 feet.
Correct. But research, particularly animal studies on cerebral arterial gas embolism, CAGE.
Bubbles in the brain arteries. Bad news.
Very bad news. Those studies haven't really shown a clear benefit to going deeper than 2.8 ATA. Some even hinted it might not be better.
So the consensus shifted.
Pretty much. Recent authoritative reviews conclude that for both DCS and CAGE, there's no strong evidence that pressures higher than 2.8 ATA offer a significant advantage.
Even the Navy's experience points that way.
Apparently so. Comparing Table 6, max 2.8 ATA, with Table 6A, which starts deeper, they found no difference in outcomes for CAGE and maybe even a higher recurrence rate with the deeper table.
So unless it's some incredibly rare, extreme, uncontrolled ascent.
Right. For almost all typical DCI cases, 2.8 ATA seems to be sufficient, and that's well within the capability of standard monoplace chambers.
Okay, let's talk fire. That's always the nightmare scenario in hyperbarics. Is the risk worse in a 100% oxygen monoplace?
Fire is, without doubt, the single greatest threat in any hyperbaric operation, period. Enclosed space, pressure, oxygen.
Recipe for disaster if something sparks.
Exactly. Now, is the risk higher in a monoplace? It's nuanced. The consequence of a fire is undeniably greater in a 100% oxygen environment because oxygen intensely fuels
It
combustion.
makes sense. A small spark becomes the big fire much faster.
Right, but the actual risk of a fire starting, that's generally considered about the same whether it's mono or multiplace, and sadly, fires still happen in both types, almost always due to a failure in safety procedures.
Like someone sneaking something flammable inside.
That's a major one. A strictly enforced no pockets policy is absolutely vital. No phones, no lighters, no synthetic fabrics that generate static.
So the likelihood of ignition might be similar, but the outcome if it ignites is worse in pure oxygen. That's a good way to put it. Which leads to the question of fire suppression. Multiplace chambers usually have systems, right?
Yeah, often water deluge systems. They spray water inside.
And those systems have saved lives in multiplace fires. Historically, monoplace chambers didn't typically have built-in suppression.
Is that changing?
There's a standard in Australia and New Zealand now that requires monoplace chambers to have a system designed to soak the patient during depressurization if a fire occurs.
But regardless of built-in systems, the focus is prevention.
Absolutely paramount. A comprehensive, strictly followed fire safety plan is non-negotiable. That means adhering to design codes, manufacturer guidelines, meticulous screening for prohibited items.
What kind of items are prohibited, besides the obvious like lighters?
Things like petroleum-based ointments or skin products, certain types of clothing, ideally 100% cotton clothing and linen only. Also crucial is confirming the patient is properly grounded to prevent static discharge.
Static electricity is a big risk. Huge risk in an oxygen-rich environment. Managing the oxygen flow in a monoplace actually helps control humidity, which can mitigate static buildup, but grounding is still essential.
And the pure oxygen limits some equipment too.
Yes, some standard critical care equipment might not be safe for use inside a 100% oxygen monoplace. Everything has to be evaluated for hyperbaric oxygen compatibility.
So the bottom line, on fire.
Monoplace chambers can be operated safely, but it puts a tremendous onus on the program and the staff to be incredibly diligent about safety protocols. Lapses can have catastrophic consequences.
Understood. Okay, what about pneumothorax, a collapsed lung? If a diver has one, maybe undiagnosed, and goes into a chamber,
Mhm.
what happens during decompression?
That's a valid concern. Boyle's law again. Any trapped air in the pleural space, the area around the lung, will expand as the chamber pressure decreases during ascent.
Which could make the collapse worse or cause a tension pneumothorax.
Exactly. Tension pneumothorax is a life-threatening emergency where the expanding air pushes on the heart and lungs. So, if a pneumothorax is suspected during decompression in a monoplace,
Stop the ascent.
immediately halt decompression. You might even need to recompress slightly while you get the right people and equipment ready. Then you'd proceed with a very slow, careful decompression.
Has this happened?
The source mentions historical cases in multiplace chambers where a pneumothorax was missed, decompression proceeded, and the patient developed tension pneumothorax. But importantly, all those cases were successfully managed after they got the patient out of the chamber.
So it's manageable, but needs vigilance. Is it a common risk for divers?
The risk of it happening from the dive itself, pulmonary barotrauma causing a pneumothorax, is relatively low because divers are screened for lung issues. It's perhaps a bigger concern in clinical HBOT for non-diving patients who might have underlying lung disease.
Is there a recommendation for handling it?
Yes, there's a suggestion that for cage caused by pulmonary barotrauma, putting in a chest tube before treatment might be wise, even prophylactically. And this advice is extended to monoplace practice as well in those specific situations.
Okay. One last practical point that was raised. Managing bodily waste during potentially long treatments.
Right, the less glamorous side. Patients are always encouraged to empty their bladder and bowels before treatment. For alert males, a urinal can sometimes be used inside.
And for others.
Catheterization is pretty common, especially for seriously injured patients or females, although the source notes that some larger monoplace chambers make using a bedpan a bit more feasible than older, smaller models.
Has this ever forced a treatment to stop?
Interestingly, the author states that in 34 years at their institution, they've never had to interrupt the DCI treatment in a monoplace for that reason.
Good to know. Okay, let's shift slightly. We touched on treatment tables. You mentioned short tables developed for early monoplace chambers. Can you expand on that? Short versus long.
Sure. The standard U.S. Navy tables, like TT5 and TT6, are often called long tables because they include those air breaks we discussed, making the overall treatment time longer.
Right.
In the 70s, because early monoplace chambers couldn't easily provide air breaks, specific short or abbreviated tables were developed. They used 100% oxygen under pressure, but without the air break intervals.
And they worked.
Surprisingly well, according to reports and reviews, including analysis of the Divers Alert Network (DN) database. They seemed effective for various types of DCI, both acute and delayed onset, and compared quite favorably to the outcomes seen with the standard long USN tables.
So even though modern monoplace chambers can do air breaks and use the long tables.
Some facilities might still prefer the short tables. Why? Well, because they have a long track record of success, they're simpler to administer in some ways, and potentially they might reduce overall treatment time and healthcare costs.
Interesting. So effectiveness seems comparable, but maybe logistical or cost benefits keep the short tables in play for some.
That seems to be the reasoning, yeah.
Okay, let's try to pull this all together. We've got monoplace chambers clearly accepted, even vital, for on-site dive and support.
Tacit approval, you could say. No real controversy there.
But for hospital-based treatment of DCI, despite technological advances, there's still this lingering debate or criticism. Why do you think that persists?
Well, as we discussed, some early criticisms were probably fair. The initial monoplace setups were more basic. Maybe there wasn't always the same focus on handling acutely injured divers compared to routine HBOT patients. And perhaps physician training specific to diving medicine wasn't always robust in those settings.
But you're saying that's largely changed.
In many places, yes. The chambers are more capable, biomedical support is better, and there's a more standardized approach to managing DCI. A modern, well-equipped monoplace unit run by a physician knowledgeable in diving medicine can successfully treat most DCI cases.
So what's the problem now? Is it just perception lag?
Partially, maybe. But there's also a concerning trend noted in the U.S. that only a minority of hospital monoplace programs seem to have fully geared up to handle severe, acute DCI cases on a 247 basis.
Availability and specialized staffing.
Exactly. It's not just the chamber, it's the system. Having physicians specifically trained in diving medicine available around the clock for emergency referrals, that remains a challenge for many monoplace facilities. And it's a problem when deciding where to send an injured diver.
So the technology might be there, but the infrastructure and dedicated expertise might lag behind in some places.
That seems to be a key part of the ongoing issue. Accessibility to truly capable 247 care, regardless of chamber type.
What about if a multi-place chamber is nearby and available? Is there any reason not to use it?
Generally, no. If a multi-place chamber with experienced staff is readily available, its advantages, like having attendants inside, are usually preferred. There's no real controversy there.
The debate is really about when the only local option is a monoplace.
Precisely. Then you face the dilemma. Do you treat immediately in the local monoplace, assuming it's deemed capable enough? Or do you delay treatment significantly to transport the diver, potentially hours away, to a multi-place center?
That's a tough call. What do the experts say?
Well-respected figures like Kinwall and Moon argued years ago that monoplace chambers are adequate for most DCI cases and cautioned against potentially harmful delays caused by unnecessary transfers to distant multi-place facilities.
Okay. What if both types of chamber are, say, roughly equidistant? How do you choose then?
Intuitively, you might lean towards the multi-place, but the guidance suggests looking beyond just the chamber type. You need to consider logistical factors, operational capabilities, and critically, the clinical expertise of the team at each facility.
So a top-notch monoplace facility within a major medical center with experienced staff available 2/7 might actually be preferable to a more distant, perhaps less comprehensively staffed multi-place unit, even for severe cases.
Potentially, yes. Even for cases needing ventilation, if the monoplace facility has the right equipment and expertise. Dan, the Divers Alert Network, actually classifies referral centers based on their overall capability, clinical quality, operational readiness, not just whether they have a mono or multi-place chamber.
So it's about the whole package, not just the pressure vessel.
Exactly. It's about the quality and availability of care overall. If you're a diver listening, you can see how the type of facility available nearby could really impact your emergency care options.
So to wrap this deep dive up, monoplace chambers have clearly evolved hugely. They play a critical role in diving safety in the field. And while they can be very effective for DCI in hospitals, there's still this ongoing discussion, often revolving around accessibility, staffing, and ensuring consistent capability, especially for severe cases.
That sums it up well. The key takeaway really is that deciding on the best treatment location for DCI isn't black and white. It's not just monoplace bad, multiplace good, or vice versa.
You've got to weigh everything.
Right. The diver's condition, the specific capabilities of the nearby facilities, both the chamber and the team, the transport time and risks. It's a complex decision.
Which leaves us with a final thought for you to ponder. As monoplace chambers become more and more common in hospitals, how do we, as a medical and diving community, ensure that divers get consistently high standards of DCI care, 24/7, regardless of whether the nearest hyperbaric facility has 1 seat or 10? How do we balance that critical need for immediate recompression against potentially more comprehensive but delayed care elsewhere?
It's a crucial question for the future of diving emergency care.
Definitely something to think about. Join us next time for another deep dive.